All right, welcome back everyone to another virtual shouting session at Hearts for Health. We apologize for the delay. We just took a little bit to get everything sorted for today's session, but we're joined by Morgan today. She is a nurse practitioner practicing medical, cosmetic, and surgical dermatology. She'll be going through a little more about the specialty, and we have a few cases for y'all today. I do have a few reminders though, before we do get started, especially if you're new to virtual shadowing or our program in specific. So we do have a Q&A at the end of each of these sessions. And if you have any questions for Morgan or any of our future speakers, please do feel free to type them in the chat. We'll also have some questions here and there as we go through cases. So feel free to type in your answers for those questions as we go through the presentation too. And then lastly, my last reminder is, in order to stay tuned with virtual shadowing sessions, if you're not familiar, we do have an Instagram page, and I'm sure many of y'all have heard of us through there. We posted our flyers over there, and we do have a couple other opportunities outside of shadowing that we do post over there on Instagram, and we have an email listserv that also has the same flyers for virtual shadowing along with our other opportunities, and we'll have those released pretty soon this month or early next month for mentorship and volunteering. We have a few programs outside of shadowing for those two areas. So if you happen to be interested in either volunteering with us or mentorship from a medical student, a PA student, a pharmacy student, or a dental student, we have those 4 types of mentors within our mentorship program. Definitely go check out our page. Like I said, the application will go up either this month or early next month. With that said, though, we're happy to take any questions that you might have about virtual shadowing or any of our programs via email. Our email address is community@hearts4health.org. Any questions that you might have, feel free to send them over there. But with that said, I don't want to take any more time. Morgan, feel free to take it away.
Thank you so much. Thank you so much, you guys, for joining me tonight. My name's Morgan Teigen. I'm a nurse practitioner in dermatology. I guess we'll get right into it. So tonight, I just want to talk about my specialty, why I love it so much, and kind of the different routes that you can take to get into dermatology and even just becoming a nurse practitioner or a PA or even pre-med. So we'll start. The overview for tonight, I'm going to go over my bio. I'm going over my career journey, and then I'm also going to go over the different dermatology specialties, medical, cosmetic, and surgical dermatology. I'm also going to go through a couple case studies, one of them being medical related, one of them being surgical related, and then the last one kind of honing in on cosmetics and that subspecialty as well. So if you don't mind going to the next slide, there's my overview. So with my bio, so I'm a board certified nurse practitioner. I specialize in medical, surgical, and cosmetic dermatology. So I decided to learn all 3 subspecialties and really hone in and gain the skills for all 3. I have been practicing for 7 years. I started my career in Tampa, but I recently moved 2 years ago to South Florida, and I now practice at Sipperstein Dermatology. Sipperstein Dermatology Group is a private practice in South Florida where I'm able to kind of specialize in, like I said, those 3 subjects: medical, surgical, and cosmetic dermatology. I do share a little bit of my career since I love it so much on social media. So if you do want to follow along on my career journey, it's at Morgan Teigen _NP. So how did I start this whole process of my career, and where did I start? So we'll go up to the next slide. So my career journey, this is just a nice little timeline of where I started. As nurse practitioners, you first have to get your RN degree. So I got my BSN and I graduated from University of Florida here in Florida. And then I acquired a position as an RN at Tampa General Hospital, which was a main teaching hospital in Tampa, Florida. And I really enjoyed labor and delivery. So I first got my position in labor and delivery as a registered nurse. From there, I decided to see if I liked the inpatient experience, see if I liked working in the hospital, 12-hour shifts. I decided at the end of that year that I was going to start my journey of applying to an MSN program. And I wanted one close by because I wanted to make sure that I was learning in the classroom with professors, and I was actually able to work at the same time. So I decided to apply for an MSN program at University of South Florida, and I started there in the fall of 2014. So 2.5 years went by. Basically my first year was strictly clinical, similar to physician's assistant school or physician's associate school. And then the second year really focused on gaining clinical experience with clinicals. So from there, I was able to do a couple of my clinicals in dermatology. I passed my certification boards and graduated with my MSN in 2017. And from one of my clinical experiences in school, I was able to get a nurse practitioner position at a private practice in dermatology in Tampa, Florida. So in 2017, I started that journey. And for 3.5 years, I worked at that company. They had a very intense internship program for me where I learned medical, cosmetic, and surgical dermatology. And then from there, my now husband lives in South Florida. So I made a little bit of a change for family and I moved to South Florida. And I started with a second private practice in Boca Raton and Boynton Beach, Florida. They have 2 offices that I go to. So it's a great work-life balance. And we'll go more into that on the next slide. So I just wanted to go over the different dermatology specialties. So some people choose to just do medical dermatology. Some people choose to just do surgical dermatology. And some people really like cosmetic dermatology. Well, I like all 3. And I learned in labor and delivery that, I wanted a very versatile specialty. So dermatology is actually really similar to that. So with medical dermatology, I do skin cancer screenings. I treat patients with psoriasis, which is a chronic inflammatory disorder. So is atopic dermatitis. I see those patients a lot. I see a lot of acne. I do treat my occasional warts. Medical dermatology is the diagnosis of hair, skin, and nails. So I do see nail disorders and I treat hair loss. Surgical dermatology is more of those procedures. So I do excisions for basal cell carcinoma, squamous cell carcinoma. I treat dysplastic nevi, so those are irregular moles. And then I do surgery for malignant melanoma. I also have some experience with Mohs surgery being an assistant. I worked with many Mohs surgeons in the past. So Mohs surgery is a specialized surgery for skin cancer that's really for aggressive skin cancers on the face. So I was able to assist in Mohs surgery and help with the closures. And then you have your cosmetic dermatology. And cosmetic dermatology is more so your Botox and your filler. We do laser treatments in our office, and we have estheticians that do our lasers. So I mainly focus on neuromodulators, which is Botox and Dysport and filler. And then I also do personalized skincare consultations. So I want to go into on the next slide kind of why I chose dermatology. And there's a couple of reasons when I was making this PowerPoint of why I feel like dermatology is such a great field. It's such a versatile specialty. So each patient is going to be so different. I may be doing a skin check in one room, and then I may be doing a skin cancer surgery in the next room. And then for the next hour, I may have, a cosmetic patient that I'm working on and doing neuromodulators and fillers. I really enjoy collaborating with other providers. In my group specifically, we have 15 other providers, and I would say about 7 of those are physicians. I would say 3 are nurse practitioners, and then the other 5 are physician's assistants. So it's really nice to collaborate with other providers. And if you have a case that you're concerned about or want a second opinion, you have that person right there. And we really have a nice way of going over cases together, staying up to date on our skill set. So it's really nice collaborating with other people in your office. I like outpatient. I did the inpatient experience, and I know everyone is different, and they like the thrill of inpatient, maybe emergency or even labor and delivery, but I really like the outpatient experience. The patients are really happy. They want to come in and see you. So it's a nice atmosphere. Autonomy and hands-on procedures. I really like that I can have my own set of patients for the day. So I come in for the day, I have my own set of patients, and I'm able to do all my own hands-on procedures. So if a patient needs a biopsy, I'm able to perform the biopsy. If a patient needs a skin cancer surgery, I'm able to perform that surgery for that patient and give them the best cosmetic outcomes for that surgical scar. And then when it comes to cosmetics, it's really nice to be able to see that patient again and show them the results. The set work schedule and no call is definitely a plus of dermatology. I work 4 days a week. So I work all days except Thursday, and of course Saturday and Sunday. So I have Thursdays off. It's a really nice work-life balance. I love my job, but of course we all need days off. So it's really nice to kind of have a day off and enjoy having no call on the weekends. And also dermatology is really strong in patient education and prevention. When we're doing a skin cancer examination, we're really asking, are you wearing sunscreen? Are you looking out for certain atypical moles? So we're really educating the patient to use sun protection. And then we're also educating patients with their chronic diseases, how to manage those diseases. So, and then we'll go to the next slide. So tips on becoming a dermatology nurse practitioner or just getting into the field of dermatology. I think the biggest thing that I tell people is just seek out shadowing and clinical opportunities while you're in school. I know that some of us don't have a choice of what clinical experiences we can have. Of course, I had my primary care experience. I even did a GI rotation. I did a peds rotation, but I was really wanting my school to give me a dermatology rotation, and they just couldn't seem to find anyone. So I found 2 people myself, and I kind of networked around and even called offices, and I was able to get 2 clinical experiences in dermatology for the semester. I did have to do extra hours because of it, because we needed requirements for primary care and other subspecialties, but I thought it was really important to just give the call myself and kind of put myself out there. I think attending dermatology conferences is a really great way once you've graduated, or even if you're really serious about becoming a dermatology PA or NP. There's really good local groups. SDPA is one in Florida that I go to. It's the Society of Dermatology Physicians Assistants, and it's a great conference every year. You learn a lot, you're able to network. So it's a great way to just start getting involved right away and start learning. I've joined my local and state NP and PA council. They usually have meetings every month, and every time they have the meeting, they go over shadowing opportunities, and they also go over job opportunities as a new nurse practitioner or PA. So it's a really nice way to kind of look into your community and see what you can do to help out, volunteer, and even just go to the meetings and see kind of what's new for the job market. And then I always tell people, just keep on networking. Networking is so important. One of my clinical experiences in dermatology, I found out about from a labor and delivery nurse when I was working, and she knew someone else that had a clinical opportunity at the job that I actually landed after school. So just make sure to network. That means go to the dermatology conferences, maybe go to a few meetings, things like this, Hearts for Health, learn as much as you can, ask as many questions as you can, and shadow as much as you can. So we'll go to the next slide. So I want to go over a few case studies. This one is more of a medical case study, but this is an 83-year-old male. He was presenting for a full skin exam. He has history of squamous cell carcinoma in situ and also dysplastic nevus with severe atypia, which is kind of a irregular moles that have atypia that need to get treated. And both were treated by surgical excision. So when I was doing a skin exam, and I find a lot of these on my older patients and patients with extensive sun damage, I found these erythematous macules with rough scale, and those are actinic keratoses. Actinic keratoses are also known as precancerous spots. So those were treated at the visits with liquid nitrogen, which is something we use a lot, and it's a procedure that I'm able to do right there at the visit. But if you can see, kind of I circled with a white marker. On exam, I also found a brown two-toned irregularly shaped patch on the mid-chest. So I decided to take a biopsy, and I don't know if you can see in this photo, but this patch is definitely over a centimeter. And it had a dark dot in the middle, which to me, I've always found is a tough finding when you find a lot of irregularities in a spot. So I just want to know what everyone's differential diagnosis would be for this particular patient.
While we wait on people getting in some responses in the chat, maybe we can go through a few questions. So just to start things off, we've had a nurse practitioner in the past, I believe. We've had physicians in the past. We've had PAs in the past. But could you go through why exactly you were drawn to being a nurse practitioner over being a PA or over being a doctor or over just being a nurse in general?
Yeah, no, that's a great question. When I went to University of Florida and studied nursing, I was really honing in on just patient care. I like the idea of nursing because I was able to kind of look more into becoming a nurse practitioner right away. So as soon as I found out about the College of Nursing and I thought about that, I thought, well, what more can I do with this? And so I looked up nurse practitioner, and I really didn't know what a nurse practitioner was when I applied for college. And I saw that you're able to kind of be autonomous and you're able to take care of patients. I always loved the nursing model, the nursing model versus the medical model. So I was really drawn to kind of the caring aspect of nursing. I'm kind of the first person in my family to choose nursing as my major. So I think it was an interesting conversation with my family at first because I didn't really understand what nursing was. I think they thought it was maybe like, a nursing home type nurse, which is a great nurse, but maybe there's not a lot of growth there. But as soon as I looked at nurse practitioner, I saw there was a lot of growth. And I love PAs. I love working with physician associates, and I love physicians, but I wasn't sure if all of the schooling for a physician was for me. I mean, being a physician just wasn't on my radar. I actually really like the idea of being a registered nurse first before becoming a nurse practitioner. But probably what drew me the most to being a nurse practitioner is that I was actually able to work the same time that I was in nurse practitioner school. And how my school worked is it was 2.5 years. It was part-time. So I took 3 classes at once. And then I also kept my full-time job until clinicals came, and I was able to go down to part-time. So that left me with 0 debt, and it left me leaning on my hospital to help me with scholarships and grants. They actually paid for my schooling. So it kind of gave me a leg up out of school. And that's really why I chose it, because I thought it was a very, very nice specialty to be in, and having that autonomy. And then also coming out of school with no debt was pretty good for me. So
100%, 100%.
Yeah.
And then one more question before we go through our answers. So when you talk about deciding on a specialty, you went through why you decided on dermatology, but if someone were to say want to hop on over to another specialty while they are practicing NP, how feasible is that? We hear, for example, with PAs that they have a lot of lateral mobility. That's the word I'm looking for. How much lateral mobility would you say that you have as an NP?
I would say tremendous. I think the biggest thing is just putting yourself out there and networking. If tomorrow I decided I wanted to maybe go into primary care, or maybe I wanted to really change, it would have to be outpatient, because I did, my track was more like family nurse practitioner or adult gerontology nurse practitioner. So it wasn't acute care nurse practitioner. But easily in the outpatient world, I would be able to switch my specialty. I think it's more putting yourself out there and kind of doing the work for it, studying for it, going to conferences for it, and really networking with people in that field and saying, hey, would you take me on to shadow, or would you take me on to train me for, 3 to 6 months? So I do think that there's a lot of lateral mobility in nurse practitioners, very similar to physician's assistants.
Good to hear. So far we have melanoma as our suggestion.
Okay. Any others?
That's the consensus right now.
Okay. Before we go to the next slide, I'll just tell you what my starting rule out was. I actually go to the next slide because I think I have just the differential on there. If you don't mind. Oh, there's what's your differential. We'll keep going. So you can go one more slide. So this was my differential diagnosis. A typical nevus would be more of a dysplastic nevus, and that has a range of mild atypia, moderate atypia, and severe atypia. So that's always in my differential, and that's probably my most common differential, even when I'm considering a melanoma. Of course, malignant melanoma is in the differential. Also, solar lenticels can look really funky. So this could have easily been a greater than a centimeter solar lenticle, which is just a sunspot. And then maybe a benign appearing nevus or a benign nevus. But we'll go to the next slide and we'll read the path report. So this is the path report. So this left medial superior chest, I did a shave biopsy and it did come back as a melanoma in situ. I'm telling you, most of the times if I see an irregularly shaped patch with a dark dot in it, I'm considering melanoma in situ immediately. So deeper sections were examined and the lateral margins were involved. So when I'm doing a surgery on this patient, I'm going to do a wide local excision with 1 centimeter margins. I was able to do this surgery, so I saw the patient back about 2 weeks later. He had a wide local excision, and then the suture removal was planned for 2 weeks. But we're not done with melanoma in situ, and I won't just see him like in a year. So we'll go to the next slide because more education and patient education is noted. So we cleared the melanoma in situ with the excision. He now has a well-healed scar, and that scar is actually just 2 weeks post-op, so it probably looks a lot less red now. I plan to see the patient every 3 months for a full skin exam for the first 2 years. That's protocol for melanoma in situ. And then after the 2 years, we'll increase the duration to every 6 months. Aside from just seeing me, the patient will now have an appointment with their primary care doctor and an ophthalmologist every 6 months, just to make sure that we're not missing any or other side of cancer, or even want to do an examination in the eye to make sure that we don't have melanoma in the eye as well. So, any questions about that case study?
No questions.
Okay. This is a fun case study, and I forgot to mention that I see a lot of rashes. And as a new grad, you have a lot of patients that are coming in the last minute. So you're going to see a lot of rashes. You got to know kind of your differential of rashes, when to do a shave biopsy, when to do a punch biopsy. So this is kind of the exciting part of dermatology. You really use your brain, especially in the medical part of dermatology. So it's kind of fun to see these rashes and definitely make sure the patient gets better. So this patient particularly, she's a 27-year-old female. She was coming in for a full skin exam. And on exam, I start with my skin exam from the scalp and I work my way down all the way to the feet. So on her ears and on her scalp, and I'm sad I don't have a picture of her scalp because it was pretty extensive. She had these well-demarcated erythematous plaques with silvery scale present on the scalp, ears, and elbows. She does have a family history of psoriasis, no family history of eczema when I asked her. I always palpate the joints because if I'm considering a diagnosis of psoriasis, and I always consider it if someone comes in with these type of plaques. I always check the joints on the fingers, and she denies any joint stiffness or pain. And I said on the exam, it was present on the scalp, ears, and elbows, and joints in hands and feet were non-tender. Her skin exam was within normal limits. I mean, she's 27 years old, and I don't expect to find anything malignant on her. So what is her clinical diagnosis?
While we wait on some answers, we can have another round of Q&A. So you were talking about networking to get clinical exposure for the type of students listening in who are mainly in college, right? Where they don't necessarily have much opportunity to have a certification outside of CPR, BLS, maybe EMT, more short-term certifications. What would you recommend for clinical exposures for them? What should they look into? What type of clinical exposures?
I would really focus on just shadowing. I would, I'll just give you an example. All summer, high schoolers and pre-PA students and even pre-med students, we have a program for Cypress Dermatology where they're able to sign up to shadow with me for a day or two. And so I've had some high schoolers, I've had some men and women in college that have come in and shadowed with me and have come for the whole day. So I really think just picking up the phone and calling, or even just bringing your resume in and saying, I'm really interested in a shadowing opportunity. Another thing that's nice to get into is research. So if you're able to get into any clinical research and just be an assistant of clinical research, I don't think you need, you don't need to be board certified in anything. You don't need to have your RN or be a PA. You can be a pre-PA or pre-med. That's a great way to just gain any clinical hours and clinical experience. But if you really just want exposure to certain fields and see what you like, I would really just walk in and ask very nicely, and you just never know who's going to say yes. But you really have to put yourself out there. Or, I've had a lot of people message me on social media and ask me their advice, and even ask if they can shadow me. And I always try to make time for these people that reach out, because I know that I was there once, and I was there reaching out, and the people that took a chance on me, you'll never forget that. So it's just putting yourself out there and trying to find ways to just inch yourself into the medical field, even if you don't have the degree yet.
And one more question on that same line of thought. You mentioned research. Just in general for the student population, I think there's a bit of a misconception that research is more of a pre-med thing, that it would be most helpful for med schools. Would you say that MSN programs, or possibly if you know of any PA programs, do they look into research as a benefit or as something that would be applicable?
I definitely think it's applicable. I mean, any great organization or company, including the one I work for, I mean, we do a bunch of cosmetic research because Robin Sipperstein really focuses on that. So she has different assistants, but I definitely think it's applicable to your resume and just for learning. When I was up in Gainesville, I took a volunteering job in the hospital to pretty much sort paperwork and try to bring patients snacks and food, and just getting yourself in there just to try to be a part of the medical field really shows up really nicely on your resume, even when you are applying for that first PA or nurse practitioner job, because it shows the effort that you're putting into and the passion that you possibly have for medicine. So I think anything that you can do is helpful, whether it's research or just volunteering.
That is definitely good to know, because
Yeah.
I know personally for me, when I was started out, it was a misconception. That's good to clarify.
Yeah, definitely.
So from the chat, we have a consensus vote for plaque psoriasis.
Yes. And you can see a little bit on her elbow too, but yes, this patient definitely has plaque psoriasis. So if we go to the next slide, we can put that, yeah, she has psoriasis. And we all have, once you become, for anyone that's pre-PA or pre-NP, once you become, an NP or PA in your field, you'll find kind of a disease or maybe something you're a little bit more passionate about. And I'm very passionate about psoriasis. I was actually able to do research at my old job in Tampa with a psoriasis registry and kind of work with that. So that was wonderful. But what psoriasis is it's a common chronic inflammatory disorder of the skin and joints. Usually looks like well demarcated plaques with silvery scale. We know that you can have inverse psoriasis. That means it's in the fold, the groin, and the underarms. We know that it can be on the nails. 30% of patients with psoriasis actually do have joint pain. So they have joint involvement. And that normally is in the smaller joints, such as the hands, the feet, sometimes the neck, and sometimes the low back. Family history increases risk. This is an autoimmune disease. Most common areas are the scalp, ears, elbows, and the knees. Nails can be very common too, and you kind of look at that pitting in the nails. For this patient case, and with all my psoriasis patients, I really, really, really work on education, because I don't know if they really understand the extensiveness of their disease. So for this patient, we discussed all options. I went over topical steroids. I went over oral medication. There's a lot of research in psoriasis right now. So we have all these great new biologic injections that can really be life-altering for patients. This patient particularly, she's younger. She doesn't probably want to take an injection, so she chose topical medications. I put her on betamethasone 0.05%, And then it was a combo with calcipotriene cream, which is a vitamin D analog that kind of pushes the topical steroid to just work stronger. I had this patient use this product daily on the scalp, ears, and elbows for 2 weeks. And then I asked her to come see me 2 weeks later. So we'll go to the next slide. And patients sometimes don't follow up. So I don't know if you can see kind of this rash. Are they able to see this rash a little bit?
Yeah.
The extensiveness of it. Okay. So the patient never followed up with me. She probably did great after 2 weeks and said, I don't need to come in. But then 3 months later, she came in with this new presenting rash. And then on the exam, I saw these well-demarcated erythematous plaques. There was some papules too, which is kind of like a smaller version of a plaque, less than 1 centimeter, with silvery scale on the trunk, legs, and arms. It was almost in this raindrop distribution, which sometimes you can see with a certain type of psoriasis called guttate psoriasis. So I was thinking about that a little bit, but then it also had this kind of small scale around it, and they almost look salmon colored plaques. So I was thinking about a couple different rashes at the same time. She got improvement with her scalp and ears, but once the patient stopped the treatment, it all returned. So a good patient history is really important, because when I asked her if she had any recent bacterial or viral infections, she said, oh, I got COVID, a month ago, and then all of a sudden this all blew up. So that's another thing to think about in the differential. But again, I discussed all treatment options. I told her what I probably thought was going on, and she still chose topical medications. So I'm curious to know what your differential diagnosis is for this case. And this is the same patient that I saw with psoriasis a month prior, 3 months prior.
Quick question, just for my own. I know psoriasis is a chronic condition, an autoimmune one, I think, too. So with that said, I'm pretty sure rheumatologists would get involved. How frequently do you find yourself referring over to other specialists in cases like these? That's
such a good question. Instead of referring, I actually like to just collaborate, because with a diagnosis like psoriasis, I want me involved for the skin, and I want the rheumatologist involved for the joints. And I want us to work together, if the joints are involved, to find the perfect biologic injection for this patient, so that I'm happy, the rheumatologist happy, and the patient's happy and safe, and that we're not missing any diagnosis. And I would say I send at least 50% of my psoriasis patients to rheumatology, after telling you that only 30% usually have joint involvement. But we've come to realize that much more have joint involvement. So instead of just sending them and having them do it, I actually like to write the biologic injection myself, and then just have rheumatology collaborate with me. And that it feels nice to kind of work with other specialties and not just send the patient over. And I try to do that with the allergist as well. If they come in with hives, you end up working with a couple different subspecialties, or a couple different specialties in dermatology, and rheumatology is definitely number one. So that's a great question.
Speaking of other specialties like rheumatology, I'm not sure if many patients or people in general will see nurse practitioners in that setting. Like, we usually will see nurse practitioners at a family medicine clinic. Dermatology clinics also seem to be a popular specialty, but just to clarify, is that option open? Can nurse practitioners really specialize in any specialty that there is? Rheumatology, endocrinology, orthopedic?
Absolutely. I think if your specialty, or if when you apply for your NP program, if you make sure that it's a family nurse practitioner program or an adult geriatric nurse practitioner program, then you're looking at more outpatient. Now, acute care nurse practitioners, once it's acute care, you're going to be, in the hospital doing inpatient, whether it's emergency medicine or maybe cardiac. But if you choose family nurse practitioner, you're really able to do any specialty. And I know some people want to see physicians, instead of nurse practitioners or PAs, but it's really a patient preference. Most of the time I'm hearing patients say, I really think that nurse practitioners do a better job than doctors. And I don't agree with that. I work with wonderful physicians. I work with wonderful PAs. I think we all do the best when we work together. But some patients prefer physicians, some actually prefer nurse practitioners, and some prefer PAs. So I think it's just patient preference. But with dermatology, I'm pretty autonomous. I don't know for the other specialties how autonomous nurse practitioners are, but in my experience, they have their own patients and I'm able to collaborate with them, which is really nice.
Also good to know. So
Yeah.
our chat, another type of psoriasis, guttate psoriasis, is the consensus.
Okay, awesome. So we'll go over the differential for this case. So this patient, this is my differential. So plaque psoriasis is always the differential. And I really think that this patient definitely suffers from plaque psoriasis on the scalp and ears. Even on the feet, you can see that those plaques are thick, scaly, and then of course guttate psoriasis. So the COVID history, the patient had a viral illness. Guttate psoriasis usually is right after a viral infection. And so we have to think about that. And then usually the distribution of it are these tiny raindrop-like papules that are on the skin, and it just erupts everywhere. Pityriasis rosea is another type of viral, maybe etiology. So it's a very common rash that I see in anyone pretty much the age of 15 to 35. And it kind of shows up as these like pink salmon colored oval patches and plaques, which this patient does have as well. So she definitely meets the age. Her clinical history of having COVID a month prior, a viral illness definitely fits it. This patient wasn't severely itchy, which usually psoriasis is more itchy than other diagnoses, and pityriasis rosea is not itchy. We'll go to the next slide. So what I did is I was really thinking that it was kind of either guttate or pityriasis rosea. So I did give her a trial of the azithromycin 250 milligram tablet, which is definitely controversial for pityriasis rosea, but you could see this patient was really erupting. It's a treatment for guttate psoriasis in case the patient has strep. And I didn't swab the patient for strep. I don't have that ability in my office, but I thought it would be a good thing to try since she was erupting. And then I also did a punch biopsy because she wasn't improving on topicals. The results of the first biopsy came back as spongiotic dermatitis. And then the pathologist said the histological findings are consistent with the clinical impression of pityriasis rosea, and clinical correlation is recommended. So when I brought the patient in at visit 4 for the suture removal, she was still flaring. Her scalp and ears were severely progressing. And she really wasn't responding. And so I kind of looked at her again and I said, why don't we do another punch biopsy and see? And I did it kind of a different lesion because she kind of had multiple different lesions going on. And with that punch biopsy, it was actually consistent with guttate psoriasis. So at that time, because of her history of plaque psoriasis and her scalp getting so extensive, we decided to start her on a biologic injection and then continue topicals at the same time. So we'll keep going on this case. So this was her follow-up. She was clear on the biologic injection, and now she's treated every 2 months and she's stable on the medication. There is probably now about 10 to 12 different biologic medications for psoriasis. There's TNF inhibitors, there's IL-17 inhibitors, there's IL-23 inhibitors. They each have their own side effects. They each have their own benefits, and they have caveats for sure, but they're very safe and they're life-altering for these patients. But I shared this case, and this is probably one of my more favorite cases that I've done, is that the take-home on rashes is that they can present different on each patient, and take a good history, use your clinical judgment, and definitely biopsy if needed. For rashes, we're doing a punch biopsy, which is a little different from a shave biopsy. A punch biopsy is where we actually take a larger, deeper tissue of skin, or deeper punch tissue of skin, and we put a couple sutures in after. So we're getting down to the subcutaneous fat so that they're really able to read what's going on within the tissue. And with this patient, she did have 2 different rashes going on at the same time. I think she had pityriasis rosea from the COVID. And then I also think her guttate psoriasis and her regular plaque psoriasis just flared, one from the COVID and one just from the stress of COVID. So I thought it was a really interesting case, and definitely she's still on the biologic injection. She's doing much, much better. Her scalp is completely clear of her plaque psoriasis, and she'll likely stay on it for a very, very, very long time. Any questions that we have about the case?
No questions here.
Okay. And then lastly, I just want to go over cosmetic dermatology. Not kind of a case study, not really, but I just wanted to show you what cosmetic dermatology is all about. So I would say 50% of my day is with medical and surgical dermatology, and the other 50% is actually with cosmetics. And when I first started out in dermatology, for my first year, I didn't do any cosmetics. I really honed in on medical and surgical dermatology. And I think it made me a much better cosmetic provider, especially with my surgical outcomes. It just made my skill set much better to wait that year and really hone in on the medical and surgical skill set first. So with cosmetic dermatology, I'm just going over neuromodulators in this case. So I'm sure everyone has heard about Botox. Another brand is Dysport. So these treatments, it's botulism toxin, it temporarily relaxes muscles, and it's all kind of known as a wrinkle relaxer. So results can last 3 to 4 months. It tends to typically kick in within 1 to 2 weeks. And the most common areas that I treat, and you can see in the first picture, that is the glabellar and lateral corrugator muscle that I'm treating. So that is in between the eyes. The frontalis muscle is the forehead muscle, and you can see the before and after of this patient. And then I also treat the orbicularis oculi muscle, which is the muscle around the eyes. So kind of the smile lines when you smile. There are advanced areas to treat. I treat them, and you can see kind of in the lower photo, the orbicularis oris muscle, which is also known as a lip flip. It everts the lip. The mentalis muscle, which actually is the chin muscle. You can see in that picture that her chin is definitely smoothed out. And then the depressor anguli oris muscle. So that's the frowning muscle. So you can see that patient is frowning. And now in the picture, she's trying to frown. But I love Dysport and Botox because you can really change the shape of a face. You can really relax a patient's look without making them not look like themselves. So it really can be a powerful treatment if you know the depth of the muscle, how to inject. And this takes years and years of experience, and this takes continuous learning. So a lot of trainings, a lot of conferences, that has made me a much better injector. And then we'll next go on to fillers. So another part of my practice is fillers. So it's a hyaluronic acid gel that I mainly use. Restylane and Juvederm are the companies. I also do Sculptra, which is kind of a collagen stimulator that is injected into the skin. So what fillers do is they fill. So they fill deep folds, and they fill areas with fat loss. Results can last 6 to 18 months, depending on the area. And the most common areas I treat are the cheeks, the lips, and you can see that there's a couple lips in this photo, the first two, and the nasolabial folds. And you can see I treated the nasolabial folds in the first picture. And then advanced areas that I treat, and this is mainly in that last lower picture, is the chin, the jawline, and then I also treat temple fillers, so right in this area. But these are advanced areas, and like I said, this is things that take years and years to kind of know your anatomy and hone in on studying, go to those conferences, go to those, late night, webinars to listen to kind of what's new in cosmetics. So it's definitely constant learning. I'm able to do a cadaver lab in a month from now, a facial cadaver lab. So I'm really excited about that because that will just educate me even more. And patients appreciate when you educate them every time you're talking cosmetics with them, because I think they're so used to someone just recommending a lot of stuff to them without telling them why. So it's been a fun cosmetic year, definitely honing in on my skill set. But besides that, thank you so much for joining me. I really appreciate it. I wish I had this when I was in school, just like a community of people to kind of support you and kind of lead you in the right direction, and just any help that you can get. So if you have, I mean, we'll go over questions, but if you ever have questions for me, please message me on social. I don't mind answering any questions, and just follow along on my journey, because I really like to see how where everyone ends up, and just excited for all you guys. So thank you.
Well, thank you, Morgan, for getting
Yeah,
this all together. I really like the cases.
nice.
They had some great detail, and it's been a while since we had a session on dermatology, but just to start things off, we'll go through just about the works, or the work life as a nurse practitioner. So about that, I know that you work in private practice, but other providers, they can work in academic centers. Some do travel work. I'm sure that's the case for nurse practitioners too. Could you just go through the options that you have between private practice, academic medicine, travel work, and if there are any others?
As a nurse practitioner, you have so much autonomy to kind of pick and choose how you want your work life to be. So private practice is great. Corporation practice kind of is what I worked for before, and that's great. That's just more offices, but still outpatient. You can definitely do travel nursing. I know that some nurse practitioners have definitely done some travel nursing post-COVID, but even just kind of like doing cases and driving in the car. I did a clinical rotation with a nursing home specialist, a nurse practitioner that really went from, kind of house to house and did evaluations. So, I'm biased because I like private practice and I think it's nice. I also like academics too. So, I would have, USF has a great, I'm talking about Florida universities, but any university that's willing to train you is always a great opportunity, because you're really going to hone in on research, and you're really going to be really working together on case studies and kind of doing the rounds. I don't know much about dermatology in the inpatient. I would say that's more like the burn unit, or any cutaneous type job in inpatient. But there is a bunch of options for dermatology besides just in private practice. Some people have skin exam buses where you can walk in and do a skin exam. Some people do on the go skin exams, for nursing homes and stuff. So you have the option. I think it's just kind of what job opportunities are available to you.
Our next question is about one of the last cases you mentioned, fillers. So what are some of the side effects of fillers, especially with long-term use?
Yeah, there are multiple side effects of fillers, and I don't sugarcoat it with my patients. I want them to know what they're getting into. But when trained appropriately and done safely, they can really improve, kind of just like the patient's overall look. The main side effects, I would say, are bruising and swelling when I do injections. You can inject a couple different ways. One of them is with a needle, and the other one is with a cannula. I have switched pretty much to all cannula work except for the lips. I still use a needle. And the reason why is because if you accidentally inject filler into an artery, you can lead it into a vascular occlusion, which can cause necrosis to the skin. And so just knowing your anatomy is so important. Going over, side effects of different areas with the patient. Under eye filler can cause massive swelling and years of swelling, depending on the day. But really, it's more so education about knowing your anatomy, knowing when to use a needle versus when to use a cannula. Cannulas are very safe. They're non-sharp tipped, blunt, almost needle looking, but they're cannulas, so they're blunt tipped. So they're going to bounce up against arteries instead of puncture right through them. So knowing what plane you're in, knowing what to use, and then just educating your patient is so important. But I do think when done right, and I think less is more with filler. I do. I think a lot of people are really trying to recommend a bunch of fillers to one person at a time, but I think if you just take it slow and just do what is recommended for the patient and do it safely, they can really have a great experience.
How many years did it take for you to begin practicing cosmetic surgery?
So I took the first year just for medical and surgical. And then the second year, I just started doing Botox and Dysport. And then I started calling on the different companies such as Galderma and Allergan to start training me on filler. So the training I got is with the companies that provide the product. They will come into your office, they will bring a trainer with them, and then you have a model, and then you'll learn and train with them. So for the first year of cosmetics, which was my second year of being an NP, I really worked on honing in on just kind of the most common areas for Botox and Dysport. And then by year 3, I started adding in the most common FDA approved areas for filler. And then as the years went on, and I got more comfortable with the anatomy, and I got more comfortable with kind of my technique and injecting, then I started going for more advanced areas. If you ask anyone, I'm the safest person you'll meet when it comes to injecting these products. I want everyone to have a good experience. So I said no a lot more when I was not comfortable doing something and wanted to take my time learning it. And then when I finally said yes, I was doing it the right way, not causing any adverse events. So I would say it's been 7 years. It's been 6 years since I've done cosmetics. And so probably by year 5, I started feeling a lot more confident in it, but it took about 5 years.
In terms of specifically dermatology, what does your shift look like? How often do you work a week? How many hours per day?
So I work Monday, Tuesday, Wednesday, off Thursday, work Friday. My hours are 9 to 5 every single day. I like the schedule. They ask me what they, not everyone gets asked what schedule they want, but they asked me what I wanted my hours to be, and I actually like to work. So I did 9 to 5, and I kept my 4 days a week. I was always 4 days a week when I started my practice in Tampa. Everyone was a 32-hour work week, so that worked out nicely for me. But really, the 4 days a week is a lot of time with patients. And how my day looks like is I, come in a little early, take a look at my patient schedule. I start at 9. I see about 25 patients a day. For me, that's not a lot of patients a day. I feel like I can spend a lot of time with my patients. I have 15-minute appointments for my medical patients, such as my skin exams, acne, psoriasis. And then I have about 45-minute appointments for my filler patients. And then I have about 30 to 45 minutes for my surgeries. So it's a nice mix of a day. And then I'm able to do my notes in between patients, and I don't take work home with me, which is, I think, a really nice part of my job. I'm never doing notes at home. I try to leave it at my job, and I try to go home and enjoy my family here.
Definitely.
Yeah.
Another question is, you mentioned this, you touched on it earlier about Mohs surgery. I know it's a pretty effective method to removing any cancerous lesions. And I know actually a couple surgeons in the area. So as a nurse practitioner, are you able to get into that sort of highly specialized level of surgery?
You are actually, and I feel very fortunate that I was able to be a big part of it. So when I first started in Tampa, 3 out of the 5 partners were Mohs surgeons. So a lot of my training was kind of assisting them in Mohs surgery. And basically, for a nurse practitioner, really the only thing you can do, because you need to be Mohs board certified as a Mohs surgeon, but really what you can do is you can help really be a surgical assistant, and then help close the patient and do the surgical closures. And then when I got this job in South Florida at Dermatology, I was able to work with the Mohs surgeon for about 3 months, and I was assistant, and I already had surgical experience, so they didn't need to train me, but I was able to do all of his closures for him, which was really nice.
Okay. And then one last question just before we wrap up the session. So you mentioned why dermatology caught your eye. Were there any other specialties you were looking into before or while considering dermatology?
The only specialty that I was interested, when I first started in nurse practitioner school, I thought I was possibly going to do women's health. And I think women's health caught my eye because I was a labor and delivery nurse. And I like the idea about education. but as time went on, I noticed that I really liked being more hands-on, and I liked doing procedures, and I liked something that I was able to do like a versatile specialty. So medical, surgical, cosmetic. And I just had a friend in the program that was really interested in dermatology as well. And I think she kind of kicked that off for me and kind of opened my eyes to it, because you don't really know if you can even be a part of that specialty. How do you know that you're able to be a dermatology nurse practitioner? So that's kind of caught my eye. And then I kind of focused on that because I really liked the idea of, doing surgery and, performing biopsies and doing a lot of patient education. And I like happy patients, and patients are typically happy when they see you in dermatology. You get to gain these nice patient relationships. I see my patients every 3 months, every 6 months, or, every year. But right now I'm in year 2 at this new position that I'm at in South Florida, and I'm really seeing the same patients over and over again. And it's really nice because you really gain a nice relationship with your patients. So that's probably my favorite part about dermatology. And I think I knew that I wanted a more relationship based type nurse practitioner position, where I wasn't just throwing the patients, away and saying, "Oh, I'll never see you again. You're in the hospital." So it's really nice to come back and have those patients you see, every 6 or 12 months.
Continuity of care is really nice to establish in a specialty.
Yeah.
And a lot of people, just maybe to add on to this with one more question, a lot of people usually associate continuity of care with primary care. Would you say that's because, is that just a misconception in general, or would you say that's because primary care facilitates more frequent visits? Like you mentioned, 6 to 12 months. That's how often you typically see your patients.
Mm-hmm.
Is that the same for primary care, or would it be more frequent?
I think you're right. I think primary care, like the patient knows, not everyone has a dermatological disease, right? So, but everyone needs a skin exam. So I may see that patient every year for a skin exam, but they may have diabetes and they're seeing their primary care every 3 months. But I think dermatology is kind of like a primary care niche in a way, because you're still gaining those relationships, but they're coming in for a more of a specialized, primary care is great, but there's a lot going on in one visit. You're trying to manage hypertension, diabetes, then the patient has, neck pain, and then maybe you're doing a skin check. Like it's a lot. So I think dermatology is nice because you can have that feeling like you're seeing your patient every 6 to 12 months, but you're just focusing on the skin check, or you're focusing on skin check and management of psoriasis. I definitely think any chronic dermatological disease should be managed by a dermatologist and not a primary care provider. A lot of the time, I'm having patients with psoriasis come in 10, 15, 20 years later to me saying my primary care said I didn't have, said everything was fine or nothing was wrong. So that's how specialties are special. They're meant to stay. A primary care cannot do everything. And they shouldn't have to. We shouldn't push so much on them. We should really be focusing on the specialties, because that's really someone that knows what they're doing, and that's expertise for the patient. So
very, very true. I think that's a great way to cap off today's session. I do have some last reminders for those listening in for our shadowers. So we do have a quiz that's posted in the chat box, the same one that y'all had your questions in. We also have that posted under our video description and also on our virtual shadowing page. Any of those 3 places will direct you to the same quiz. It's a Google form, just send questions, and you have to have 6 or more correct in order to pass. If you do pass, we'll send you over a certificate that will be sent immediately. So definitely check your inbox once you're done with the quiz, or if you don't receive it there, check your spam folder. It will be due next week on Wednesday, July 19th at 11:59 p.m. Central Standard Time. So just be sure to get it done before then. And for our next virtual shadowing session, we're going to have one next Thursday, not next Monday. We will not have one on Monday, but we will have one on Thursday with Dr. Shapiro. He's a spokesperson for the American Academy of Pediatrics and is the medical affairs officer at Alta Med Health Services. He'll be talking about his role in physician leadership and also a little more about his specialty, pediatrics. We'll see him at 7 p.m., just our usual time, 7 p.m. Central on Thursday, July 20th. With that said, though, if you want to get involved in more sessions. We have these typically every Monday and Thursday. For the next 2 weeks, we will not have them on Mondays, but for the weeks following, we will. And like I said, we do post those on Instagram. We do post those over our listserv. Morgan also has her Instagram handle. Let me share my screen one more time. Definitely get in touch with her if you have any questions. We really appreciate you offering your help, Morgan. There's a lot of students who really appreciate that.
Absolutely. I wish I had that when I was in school. So, utilize it if you can. Ask me anything.
100%. Whether you're dedicated to being an NP or whether you're just considering the profession, I'm sure she'd be happy to answer any questions. But that's going to wrap it up for today. So let's hear some thank yous in the chat for Morgan getting this all together. And that will wrap it up. I hope you all enjoy the rest of your week.